Thank you for joining the Center for Financial Security for our webinar today, Financial Coaching and Medication Adherence, the Potential for a New Model. My name is Hallie Leinhardt, and I'm the Outreach Specialist for the Center for Financial Security here at the University of Wisconsin-Madison. We'll begin our webinar today with an overview of the study and a presentation of findings. We'll then welcome discussants from Covering Wisconsin and the Asset Funders Network to speak about their work in this area. There will be time at the end for audience questions and answers, so please feel free to submit your questions throughout the webinar in the Q&A box located at the bottom of your screen. I'm very excited to introduce our presenters for today's webinar. J. Michael Collins is Faculty Director of the Center for Financial Security here at the University of Wisconsin-Madison. Allison Espeseth is the Development and Operations Manager for Covering Wisconsin. Abby Hughes-Holsclaw is Director of Membership and Engagement for the Asset Funders Network. And finally, Colin O'Rourke is Senior Research Specialist for the Center for Financial Security here at UW-Madison. Colin will facilitate the Q&A session following presentations. Before we begin our presentations today, I would like to turn it over to Sarah Willis. She's Program Manager at the MetLife Foundation, and they have provided generous support for this work. Thank you, Sarah.
Thanks, Hallie, for that introduction. For those of you who are unfamiliar with MetLife Foundation, we're really pleased to support this work. It's part of our kind of national and international strategy. We've committed $200 million over 5 years to really support solutions to financial health for low and moderate income people. And when we're thinking about financial health, we're thinking about providing more than just access to quality financial products and services, really going beyond thinking about day-to-day aspects, planning for the future, and how does one become more resilient against shocks. And thinking through that, we know that that journey to financial health is most certainly correlated with physical health. So it's for that reason we're really excited to support the work at the center at UW-Madison or Wisconsin, and I promise not to be biased because I'm from Wisconsin. We really do believe in the work that and that it will perhaps lead to great advances in the field. So without further ado, I'll turn it over to Michael Collins.
Great, thank you so much, Sarah, and thanks to MetLife for supporting this work. We really do appreciate the ability to take on this project, which has been sort of percolating in the background for a couple of years now, and really gave us the ability to dig deep into this topic. So my name is Michael Collins. I'm the director here at the Center for Financial Security, and I do a lot of work around household finance and financial coaching. And the topic I'm going to talk about for the next 20 minutes is around how financial coaching can play a role with medication adherence, and I'll talk more about what I mean by that in a minute. This is going to be part of a report that will be released this afternoon, and is really the beginning stages of a probably multi-year project that we'll be involved with to try to further understand how financial management can result in people changing their health behaviors. So let me thank the other, besides MetLife Foundation, also the Annie Casey Foundation has been a supporter of this. We've had some support from the University of Wisconsin, the Provost Office, and the Vilas Award Program here. And then also the nonprofit credit counseling agency, Clarify, has been a great partner, and you'll see some data from them in just a minute. So thank you all. So let me first start talking about why we're focusing on this idea of financial management impacting adherence to treatments. And the issue really comes down to there are some treatments, there are some therapies that people take part in where you have to pay in advance. And physical therapy is an example, and then the most common example that we probably all are familiar with is there are medications. You get a prescription for a medication, particularly a chronic medication. You have to refill that prescription every month, every 30 days, or however the term of the refill is, which means you have to come up with a copay in order to get that therapy, to get that medication in a timely way. This idea of having a copayment is borne out in the sort of economic theory of moral hazard. If it's just free, if you had no copayment, then we would all consume too much health care. Now, we can debate about how much that actually affects our behavior, but that's sort of where it comes from, is you want to have some skin in the game. You want to share some of those costs, and we'll be more careful about what we spend if we take on more of those costs as opposed to having no co-payments. And this is why we're increasingly seeing co-payments. And it doesn't matter if you have the cheapest insurance plan or the best insurance plan. Over time, all insurance plans are going to more and more co-payments. The other thing we're seeing is more deductibles, higher levels of deductibles where you have to spend so much out of pocket before you get to the point where the insurance kicks in and pays. And so these, oftentimes their acronym of MOOP is put out there, medical out of pocket, is put out there as a major issue that people are facing. And I want to distinguish these MOOPs from other kinds of medical costs that people face. And certainly when an uninsured person goes to the emergency room or somebody has a large uncovered expense, then that can become a serious financial liability. Sometimes those medical collections can turn out to be go to the credit record and become a collection and become medical debt. That's not what we're focused on here. I'm not saying that that's not an important issue or that there aren't really good programs that are trying to deal with people who are facing medical debt. We're really trying to get at those payments that people have not expended, where they haven't spent the money on the medication or the therapy because they can't afford it, because they're not able to come up with the, say, $20 or $25 that it takes to make that copay or to manage those deductibles. So this is an issue that isn't about necessarily the uninsured. In fact, it's probably more of a potential problem for people who have insurance but have a chronic condition that then requires a regular ongoing copayment or other ongoing costs that they have to try to manage over time. So that's really our focus. And again, we're not in any way saying that those medical collections or other major financial issues that people face related to their health care aren't important. They are important, but we're trying to really focus on what we think is one area that might be well suited to being managed by financial coaching. And we can talk more in the Q&A about how far the financial coaching kind of models could go for people who have various more acute financial problems. But in this case, we're really talking about this transition for people who are taking on regular chronic costs. So the big thing that we worry about is that these upfront payments, these payments that you have to make before you can get a medication or before you can get a service, will discourage people from engaging in health behaviors that are otherwise productive and will help them achieve a higher level of physical well-being. So they might avoid treatment. They might not fill a prescription when they first get a prescription. They might delay treatment, meaning that they have a 3-day supply, they run out, and they wait until they can accumulate enough money to make the copay, which means they have a gap in their medication, which for some medications can be therapeutically very detrimental. Or they just skip the treatment altogether. So some months we take it, some months we don't. Sometimes we split pills, come up with other kinds of ways to stretch out the medication. And of course, all of that either reduces the value of the therapy or in some cases can make people, certainly not as healthy and sometimes less healthy than before. So we want to really look at how people are not engaging in these health behaviors like filling a prescription or following through on a therapy because these upfront copays or upfront payments become a barrier to continuing with care. So medications are the most common example. About half of Americans have some form of medication in any given year, a prescription medication. And the average prescription drug on an annual basis has about a $283 out-of-pocket. And as you look at that, you might say, well, that's not that much. You stretch that over 12 months, it's not that much money. But, add that up. That could be a car payment or two for some people. And if they haven't had to accommodate that in their budget before, the sudden onset of a new condition where they have to adopt that monthly cost actually could become a constraint. And something else may have to go. And if something else can't go, then they may not be able to follow through on the prescription. And in fact, in the data that we've looked at, from the last data we looked at was 2014, a little over half of people who have incomes less than $25,000 in a year they report that they're struggling to pay their out-of-pocket costs for health care. And if you plot any trend line of insurance plans and whether they're employer-based or individual-based plans, out-of-pocket costs are rising. More and more of us are paying more and more for each out-of-pocket expenditure that takes place. And there's very few kinds of treatments anymore that don't have some kind of out-of-pocket expense. So the question we have really is how well the households manage their finances. So we're really focused on the household financial management side as they take on more costs. And the answer is that some families really struggle. The imposition of a new therapy, which will make them healthier in most cases, can become a financial burden, and that financial burden might actually discourage them from following through on their health care. So this is data from the MEPS, which is a survey collected on medical expenditures by the NIH. And this data is looking at people who say that they have been diagnosed in the last year with one of three very, very common conditions, and some of the three most common diagnoses that people have for a chronic condition. So diabetes, cardiovascular disease, and then hypertension or high blood pressure. And these are the out-of-pocket costs just for the drugs, just for the medications that people take in that first year after they are diagnosed with one of these conditions. So for diabetes, it's a little over $400. For cardiovascular disease, it's a little over $500. For hypertension, a little over $300. These are very common diseases, especially as people age. Also related to many other both genetic and lifestyles that people have. But you can imagine for some people this is a significant amount of money. If you're earning on a monthly basis, say $2,000, spreading out a $500 payment over 12 months might be a lot to try to absorb, and becomes a discouragement from people following through on their care. And in fact, if we look at that same MAPS data, the expenditure data, and we look at whether people report any emergency room visit costs in the same year, that they also report having trouble paying for the copays on their medications by different diseases, in this case by diabetes diagnosis and high blood pressure or hypertension diagnosis. The odds of them having reported an ER visit cost are about 5 times higher for people who say that they missed or delayed their medications because of the cost. And the question was about the cost, not because you don't believe in it or because you're afraid of side effects or you don't trust your doctor or other kinds of reasons. Those were other options. These are people who just say because of the cost. And for people who have high blood pressure, it was about 10 times higher. They're 10 times more likely to end up having an emergency room expenditure in the year that they reported having a medication cost problem. So, these are real binding constraints that people have. Missing prescriptions is somehow correlated with people's health status and ultimately how well they're able to manage their health care. Looking at another data set, this is a data set of financial behavior called the National Financial Capability Study by the FINRA Foundation. And in that data, they asked people if they've had problems keeping up with the cost of their medications. And so the green bar here are people who are, or the aqua bar, are people who say they did not have any problems in the last year paying for prescription drug costs. And the blue bar are people who say they did have some problems paying for prescription drug costs. And you can see that the people who self-report having problems keeping up with their prescriptions, which is abbreviated here RX, are less likely to report that they're good at dealing with their finances. They're less likely to say that they have set financial goals, and they're more likely to say that their spending exceeds their income. And these are relatively large differences in many cases, and all significantly different statistically. So there seems to be some combination of financial capability and problems managing finances that seem to be correlated also with problems managing the costs of a prescription. The other issue we can think about is one of the problems that you might have is the lack of liquidity. So we think about liquidity as being predominantly in the form of some kinds of savings, but also in the form of credit. I could put my copay on a credit card, or I could somehow use credit to smooth my consumption, smooth my income when I have these shocks, these expenditure shocks, like a copayment for a drug. And yet we see people who say that they've had some prescription drug cost problem are about 20 points less likely to have a credit card. They're less than half as likely to say that they could get approved for credit if they were to apply for credit. And they're more than twice as likely to say that if they did apply for credit, or when they did apply for credit, they were turned down for it. So clearly some correlations here with credit problems that people have. The last piece of evidence I would show that shows these associations between financial problems and prescription drug cost problems are using the SHED. This is the Survey of Household Economic Decision Making by the Federal Reserve Board. And here we're able to track households for up to 4 years. And so we get to see the same family for up to 4 years and see changes in their status. So each of these bars, each of these rows is the change in, so the case of the first bar there is uninsured. And that's not too surprising. When people go from being insured to uninsured, they're about 5 points more likely to say that they have a prescription medication cost problem. They're having trouble keeping up with their medications because of the cost. Which is a little bit more surprising is that we have almost the same size effect from being turned down for credit. So almost as much, as an effect we see on the uninsured, going from insured to uninsured, we see as being turned down from credit. So a strong association there with the credit problems that people might have. Similar pattern with people who say that they have gone from a better than poor credit score to a poor credit score. Again, they have a problem managing their ability to keep up with the cost burden of their medications. And then people who self-report that they're having difficulty getting by financially or just getting by financially are also more likely, once they change to those statuses of having more difficulty, they're more likely to say that they have more of a problem keeping up with the cost of their medications. So all these are controlling for basically everything else about the household you can think of. It uses what we call a fixed effects model. So everything else that doesn't change about the household, their education level, their gender, their income, all those kinds of things. And then also as things change too, so we have income, which is significant and suggests that as people's income changes and goes down, they're also having more trouble keeping up with the cost of their prescription drugs. So again, this is sort of following the same people over time, and when we see these changes in their finances, we also see a sort of correlation and a change in their medication burden, their ability to keep up with their prescription drugs. All of this sort of paints a picture, I think, that we're seeing families struggling keeping up with health behaviors, with medication adherence as their financial situation changes, and that financial capability might play a strong role in how well people can adapt to these changes. So here's some data I talked about just at the very beginning from Clarify. So this is a Philadelphia-based nonprofit that does consumer credit counseling for a wide variety of different kinds of conditions and issues, and has actually done a lot of work with clients in healthcare settings in terms of managing their finances. And here we just see from those clients in the right column who say they have everybody in this sample had some prescription drug that was screened in for having a prescription drug. And then if they did they have any problems keeping up with the cost of that drug? And you can see that the people who say that they had cost problems were more likely to say they were spending more than $20 a month for their monthly medication spending. These are mostly out-of-pocket costs like co-payments. They're also more likely to say they're not at all confident in their ability to keep up with, make ends meet when they have a financial emergency. And they're also much more likely to have any late payments in the last 30 days, and this is taken from their credit report. They also have lower credit scores by about 24 points. So, there's, again, this consistent sort of story of people who are having trouble keeping up with their medication copays are also showing some signs of other financial vulnerabilities. So the model that we're proposing, and we'll hopefully get to talk more about, we're abbreviating as FinMed. So FinMed stands for the Financial Interventions Nested into Medical Practices. And the model that we're describing here today, and is in the report that will be released later today, is a financial coaching model that's brief, solution-focused coaching. So this is goal-based coaching based on the client's goals and desires, but it's also brief and very focused on a solution to the problem that they're facing, which we hope that the clients generally will articulate as around they want to be healthier and they want to take steps in their health behaviors And so their goals generally will be around using finances to enhance their health behaviors. The target of this really are patients who have insurance and who have had a recent change in their out-of-pocket costs. Their MOOPs have gone up. So typically it's problems paying for copays, but it might also be managing deductibles or other kinds of expenses. This is mostly phone-based counseling. We want it to be as immediate to the prescription as possible, sometime between getting the prescription and filling the prescription or refilling the prescription, with some kind of follow-up that oftentimes might be, instead of phone-based, text message, SMS text, or email-based, really because you just want to keep in front of the client or the coachee as much as possible. So we assume that the phone-based counseling or coaching will be about 30 minutes or so with 2 or 3 follow-up contacts of some kind. The goal of this is really that the patient figures out what their health goals are for themselves and that they have the motivation to change their financial behaviors to achieve those health goals. We don't know exactly what clients will articulate in terms of what their goals will be, but the idea of the coaching session is to help clients come up with a plan so that by the time of their next refill, they'll have the liquid resources available to make that copay. If they have 3 prescriptions, each of which has a $15 copay, they need to have $45, and they need to have that $45 before the 30-day expiration of that refill on that prescription. And so helping them to set that goal and then hold them accountable to follow through with the steps they need to make sure they can achieve that goal. And then some sort of follow-up to make sure that they're sticking to whatever they said they were going to do, whether that was savings or credit or some other mechanism that they would have to be able to make sure they have those liquid funds when the refill date comes by. So in terms of next steps on this project, at this point we've really just used secondary data that we've been taking from other surveys as well as from data that Clarify has collected to develop the skeleton of a model. We're now testing that model with some real-world applications, talking to practitioners, interviewing people in financial coaching, in health coaching, in credit counseling, and people with experience and expertise around health insurance and prescription drugs and pharmacy plans. We're going to continue to design the program based on their feedback and begin to do some initial training with some financial coaching staff. And then begin thinking more about who and how to target this particular intervention. It might be best targeted to a particular diagnosis or to a particular patient subset, perhaps a patient subset involved with a particular healthcare system or a health insurance plan that has a sort of common schedule for co-payments. And then we also are going to spend some time thinking about how to really market this to consumers, because we ultimately want this to be a program that people want to take part in, that they recognize that they are going to have some trouble keeping up with their copays. They want to be healthier, and so this is a step they can take in order to make sure they can manage those copays in order to become, reach those health goals that they have through their financial behavior. This summer and fall, we're going to be testing FinMed in the field, first around take-up in a healthcare setting to see how much patients have an interest in taking part in a program like this, and then also trying to do a randomized trial among clients who self-identify as having some problems managing their medication costs and have some prior experience with credit counseling or coaching in some kind of context. What do we expect to see from this? Well, one is we're not predicting that everybody's going to want to take part in this. Not everybody's going to recognize they're going to have problems with copays. Not everybody's going to be motivated to try to change their health behavior, or even if they are, they don't want to make any financial changes. And so we really want to focus on those people who are ready. And so we anticipate that if we roll this out, we'll have about a 40% take-up rate. That's an estimate. We may be off, but that's sort of our expectation. We would think over time that people who are exposed to the FinMed model will have an increased rate of refilling their prescriptions. That should lead them to have better health status, fewer emergency room costs, and reduce costs to the health system overall. And importantly, it should reduce financial stress. And one of the reasons why people maybe feel financial stress is that they have this struggle with trying to take care of themselves and take care of their family and the financial burdens that might go with that. So I'll just wrap up and turn it over to our discussants. But I mean, if nothing else, I think what we're trying to pursue here is a model of financial coaching that's embedded into a system. In this case, one of the most pervasive systems, and that's the healthcare system. We really are seeing in this model financial capability as a means to an end, that we want people to increase their physical well-being and their overall well-being, and that financial capability is just a tool to help them achieve that. We are trying to think about a very, very focused intervention. Oftentimes financial capability interventions are very broad. You know, anybody can come for any reason. This is very, very targeted, and we might get to the point where it's targeted even by diagnosis. And that perhaps is a trend we can think about in the financial capability field or the household finance field generally. You know, ultimately, I think we're moving towards a model that might be sustainable. If we can truly show that this program could save costs for patients, could improve healthcare outcomes, could reduce emergency room costs, to increase adherence, so that people are sticking to their pharmacy prescriptions. This might really be something that the system, the healthcare system or the insurance system, and ultimately patients could begin to take on as part of the system, and would become a sustainable way to fund financial coaching, which, you know, has been a struggle for the field. It's largely been a field supported by you know, subsidies and grants, and so this might be a way to really build it into a system in a sustainable way. So I will stop there. Thank you.
Great. And so thank you, Michael. This is Allison Espeseth with Covering Wisconsin, and I will be going over a series of slides here. So thanks again for having me as part of this webinar today. And I'm going to be giving you a quick overview of some programming that I direct within my organization, Covering Wisconsin, which focuses on helping consumers understand and make more informed choices about paying for their health coverage and their health care. So that's me, Allison Espeseth. I'm the Development and Operations Manager with Covering Wisconsin, which I'll say a little bit about in just a moment. But first, I just want to say the obvious, health insurance is complex. This is something that we have been working on a lot within Covering Wisconsin. The technical specialized terms, how it works, the math, the interplay between healthcare clinics and systems, and then also with insurance issuers. And then when you add in the very fact that because you're also dealing with something you or someone you care about has a health issue or injury, that can be very stressful and difficult to cope with. All those things combined, it's a challenging situation. And one bad or uninformed choice can lead to financial trouble. So Covering Wisconsin came about in 2003 by way of initial funding from the Robert Wood Johnson Foundation to try to help simplify the complexity of health insurance for consumers. And at that time, we were focused on public Medicaid and CHIP coverage, which we still are, but we've also really expanded to look more broadly at ways we can help the public and even practitioners and other professionals make sense of health insurance. We're based in Wisconsin, housed at the University of Wisconsin in Madison. We have another office in Milwaukee. We work with another 6 subcontracted agencies in the state as well. And since 2014, we have been a federally funded navigator entity, which means we have numerous staff who work directly with consumers to help them select plans on the health insurance marketplace as well as with Medicaid. And with this navigator work and this much more intense engagement with the public, particularly many who are very unfamiliar with health insurance, maybe haven't had it before or have had it but sporadically, we've had to think quite a bit about how to present information in a way that is both accurate but also actionable and simple and memorable. We've quickly realized that we need to think more broadly about the education and the assistance we're trying to give. So beyond just giving the information, but rather how are we providing that information? And so we have started framing the help we give regarding health insurance in terms of literacy skills, particularly health insurance literacy. So simply, this is the understanding of how to find and choose health insurance and then to use that health insurance to access care. So for most of us, when we hear literacy, the first thing that comes to mind is just the ability to read and write. But understanding information, including health insurance, is not simply about being able to read the words or understand the technical meaning. And as you see from this picture, there are many other elements involved, such as being able to communicate verbally, to hear and to understand what you're hearing, not to mention just also the listening skills, and of critical importance to health insurance, numeracy. So working with numbers, knowing how to add and subtract, multiply, divide, understanding and not being scared by percentages, things like that, as well as critical thinking and analysis, which are skills that can really take a long time to develop and hone. So in our work, we've really started to focus on all parts of understanding. And this just relates to those last two elements especially. So much of working out health insurance and financial issues are like story problems. So that real-world application of numbers can be a big challenge for many of us. If you put a decimal in the wrong place, or if you multiply when you should be adding, you're trying to solve for X, not to mention figuring out all of that from just verbal or written information you're given, which is usually not in a neat and tidy kind of math problem sort of way. And it may feel like having low literacy is something just a small fraction of the population is challenged by, but in fact, when we look nationally, the percentage of adults who have basic or even below basic literacy is 44%. So this means that 44% of the population may have difficulty with things like navigating a bus system or adding the amounts on a bank deposit slip. And so when we drill down a little bit more, so before I was looking at literacy, and now we're looking at health literacy on this slide. And so the percentage of those who are basic or below basic jumps. Now we're talking about a full 74% of the national population who struggle with things like finding a doctor or knowing where to go for care, communicating health history with a provider, understanding probability and risk of taking or not taking recommended treatments. And this chart doesn't single out health insurance concepts, so health insurance literacy, but the available evidence indicates that lack of comprehension for health insurance is likely just as low. So given all this, Covering Wisconsin has been exploring how can we better provide information about getting and using coverage to pay for care in ways that are accessible to even those with basic or below basic literacy skills. And really, because health insurance information is so complex and ever-changing, this is likely to be helpful to most of us. So this follows the approach used in literacy and health literacy communities called universal design, which recognizes that people of all literacy levels benefit from education and information that's presented in a very accessible way. And for those who feel like they then want more information, they can certainly seek it out. This, it becomes a baseline or a jumping off point on which to seek additional information. So this slide summarizes the steps that Covering Wisconsin has been taking, and I'll next, after this, I'll show you just kind of what some of these resources, what the end has been for some of these resources. But primarily in this slide, I just want to share that the heavy emphasis we really do place on getting consumer input and feedback. So we gather ideas and thoughts from a wide variety of organizations and agencies that work with consumers relating to health insurance and paying for care. So we solicit information from their staff and their members and their clients. We are looking for things that are confusing, questions they have, how they think about health insurance. So basically, we want to provide information that addresses their needs and also frames it in the same way that they are thinking about it, which may not necessarily be, and often really isn't, the way that we, and I'm speaking actually of Covering Wisconsin, how we even tend to think about providing information. So a good example would be health insurance terminology. So many publications that are out there will simply put together a list of terms and definitions, like health insurance terms and definitions. but most people don't seek out a glossary when they're looking for information. So instead, they need to know the definition of the word, say, premium, in the context of figuring out what plan they want to sign up for. That's the moment at which they're thinking about that word and realizing they don't really know what it means. And beyond getting initial consumer input, we also get consumer review of our draft content. So we do this one-on-one or sometimes in focus group settings, gathering reactions to what we've put together. And we ask questions like, what is the first thing you look at on this page? Or what words do you think somebody might not understand? Or what do you think this particular document is about? So we're really trying to get their perspective and making sure we're communicating what we think we're communicating. So the results of all this are mainly three things. One, we have our individual single-page how-to guides, which you see here. We also have consumer educational workshops, which are built off of many of these how-to guides. And then we also do trainings for professionals on the materials and about talking with their clients and consumers about these topics based on all of this background research and exploration that we've been doing. So many of these are specific, well, I shouldn't say many, some are specific to Wisconsin. As you see, we have one here called Badger Care Plus, which is our state's Medicaid program, but others are applicable more broadly. And the how-to guides in our consumer education use multiple strategies for making them accessible and hopefully effective. We're still looking into that and continuing to explore effectiveness. So this includes using plain, everyday, conversational language in words that are understood by those with lower literacy. We also use lots of white space and large font to make the reading easier. We try to really limit the number of concepts included on each individual document, especially when we're doing our workshops, really keep the content narrow, really focusing on only the information that is of interest to that audience at that moment, as opposed to just trying to throw a whole booklet at them. We try to use pictures that help communicate the information as opposed to just pictures of families or things like that that just might be interesting to look at but don't help to communicate, especially for those who might be challenged by some of the words. We want to attract their attention with images that are relevant. And most importantly, we really try to use action steps as opposed to providing the information in a narrative that kind of asks the reader to figure out on their own what they should do. We really just list it out. Okay, step 1, step 2, step 3. So these next slides just simply show a few of our sheets in a little more detail. So this one talks broadly about how to get started in finding a health insurance plan and thinking about costs. As I mentioned before, this incorporates with action steps terms, but we don't just use it as a glossary. It's kind of, here's somebody who wants to get started and trying to find health insurance, and as you go, you're going to learn about what these terms mean. And we use those pictures as well, as I mentioned. Here's another one that addresses what you can do when you get a medical bill that you feel you can't pay. In this one, we have the words that people can actually say. We actually try to give them prompts of if they don't know what the right question is to ask. Here, you can use this question. And then finally, this one is really just still in draft form, but I did want to share it given the topic of today's webinar. But it's focusing on understanding formularies and prescription drugs. And it's in the process of being consumer reviewed. And so finally, this is just all of these sheets that we have been producing. As I said before, many of them are nationally applicable. They are available on our website, and they're free to download and use individually. And we do work with agencies who like to use them more broadly. But yeah, they're available, and we do encourage people to use them. So that is all, and I can turn it over to Abby.
Thank you so much, and good afternoon. I want to express on behalf of the Asset Funders Network our appreciation for being invited to join the conversation today. My name is Abby Hughes Holzclaw, and I am the Director of Membership Engagement for the Asset Funders Network. And just so you know who we are, the Asset Funders Network is a membership organization of diverse grant makers advancing the economic opportunity and prosperity for low and moderate income people, specifically through philanthropy. And we go about our work in a variety of ways, one of which is through commissioning issue briefs. And today I'm excited to share with you and showcase our latest brief on the relationship between health and wealth. The title is The Health-Wealth Connection, Opportunities for Investment Across the Life Course. I'd offer a special thank you to our 4 funders of the brief, the California Wellness Foundation, J.P. Morgan Chase & Company, the Richmond Memorial Health Foundation, and the Baptist Health Foundation of San Antonio, Texas. The brief, which was released earlier this year, along with the authors Dr. Jason Purnell, who is a professor at Washington University, St. Louis Brown School of Social Work, and Dr. Anjum Hajat, professor at the University of Washington School of Public Health. The brief specifically uses research and data to make a fact-based and compelling case for investment in strategies and policies that consider both physical well-being and economic stability of individuals, their families, and communities. And what we know from this research and the brief is that people's financial well-being, in fact, does impact their health and vice versa. And beyond healthcare access and affordability, which is obviously a hot topic these days, and critically important, wealth and numerous factors related to where people live, work, and play also impact a person's health. And further evidence shows that health impacts are more significant for low-income vulnerable populations. And recognizing the interconnectedness of the challenges, the Asset Funders Network would say it stands to reason that the solutions actually can be or should be linked. And the brief really explores this tremendous opportunity we have to bridge funder and practitioner interest across silos to make stronger connections between wealth building, economic security, and health. And in their research, Dr. Purnell and Dr. Hajat really explore how wealth and health are related, and specifically how they are related over the course of one's life. So, for example, in the brief, which I encourage you to read, the authors look at the stress pathway, as you can see in this diagram. And let me say, it's definitely an oversimplification of this, but I'm trying to really summarize the pathways in which chronic stress gets under the skin. And stress hormones coupled with other responses can lead to memory impairment, cognitive dysfunction, and the psychological pathway is but one mechanism by which chronic stress can really ultimately lead to disease, and another pathway being through unhealthy behaviors. And the brief goes much deeper into this. We see that good health is certainly associated with higher wealth, income, as well as better employment and education. And in addition, the brief also explores how greater future orientation can help prepare one towards better outcomes. So for example, we know there's evidence to support savings in childhood is associated with college attendance and completion. I wanted to specifically highlight one of several graphs that you would find in the brief, and in this one you'll see that while the top 3% of earners hold 54% of the wealth, only 90% of the bottom earners hold only 25% of wealth. And we know that adults with more financial resources have better health and live longer lives. So at the heart of the brief is really one question, and that's throughout one's life course, the challenges of health and wealth are connected, but why aren't the solutions? And so in the interest of time, I thought I would share with you but one example that the brief really lifts up and connects to the conversation we're having here today, and that is from PRESA Community Center. And PRESA is a multi-service center providing after-school summer programming for children, senior adults, activity, nutrition center, emergency food assistance, free income tax prep, counseling service, and so much more. And the families served by PRESA Community Center typically live in the southern quadrant of San Antonio, where PRESA is located. Families typically have low education completion levels and very little higher education. And PRESA serves a large portion of single-parent homes or blended families with children from both parents. And because of the low education levels of parents, it's often necessary that the families in this community work at least 2 jobs to make ends meet. And because of working so many jobs, they often have limited time to spend with their families. And when they do, quite honestly, they're tired from their workload and stressed. And the mission of PRESA Community Center is really to improve the lives of this community by providing access to needed resources and tools for both social and personal transformation. And the philosophy and mission of PRESA is really to help add tools to folks' toolbox in this particular part of San Antonio. And to support the community, which also has a high incidence of individuals with health issues, PRESA launched Project Puente. And Project Puente includes, as a component, which I'll highlight today, community health worker certification, which is offered throughout Texas through universities and community colleges. And this effort really builds on the center's success with a small business academy model where they were reaching non-traditional learners in a non-traditional location. And so they became a site for CHW certification. And in 2012, the center began the process for the certification, and within 10 months, they became the first certified site in Texas that wasn't a community college. And one success story that's risen out of this work is a top graduate in the second class that they hosted was a single mom with 6 children who came into PRESA for food emergency assistance at first, but is now employed as a certified health worker making $15 an hour. And so through a partnership with Baptist Health System and PRESA, these community health workers are working with recently discharged patients with congestive heart failure and diabetes related and other related issues to provide a continuum of care to improve health outcomes. And the community health workers, or the certified health workers rather, serve as bridges between community members and healthcare services. And these certified health workers are in particular uniquely qualified as connectors because they live in the community in which they work, they understand what is meaningful to those communities, they communicate in the language of the people, and they recognize and incorporate the cultural norms that are so important to help community members really navigate their healthcare services. The certified healthcare workers are working with patients to ensure that they understand their medications, understand needed lifestyle changes, as well as make sure they follow up with care. And together, Project Puente and the Baptist Health System have developed a patient-centered discharge process that is culturally and linguistically competent, improves patient utilization of community-based support services, and addresses the needs of persons experiencing disease progression or end-of-life issues. I would also say there's specifically 7 pillars of service that are included in the project, and I can highlight those for you very quickly. One is the in-hospital visit that happens where an individualized education plan takes place that's really built on the client's needs. A post-discharge home visit within 24 to 48 hours after being discharged, and weekly telephone follow-up in between visits. Prompt scheduling of specialty care visits within 3 to 5 days of discharge. medication access, self-management, and adherence, encouragement of active participation by other patient family members or caregivers, greater health knowledge and retention, using some teach-back methods that they use, and patient health record recordings for ensuring that there's a continuation of care. And so far, the state readmission rate for diagnosis has been 25%, local readmission rate for diagnosis 14%, and the patients from Project Puente readmission rate has only been 7%. So they're seeing some great outcomes with this effort. And I'll leave you just with the final thought that we hope the brief and the example I shared is just one demonstration of how funders, and the Baptist Health Foundation of San Antonio, Texas is a particular funder of the PRESA Community Center for this work, how funders, practitioners, and other stakeholders really have an opportunity to bridge varying interests and crossing silos to make stronger connections between wealth building, economic security, and health outcomes. So with that, I'll turn it back over to Colin.
Thank you, Abby, and thank you also to Sarah and Allison for joining us today. We now have a little bit of time for Q&A, but first I want to make a quick plug and let everyone know that we are going to be releasing our report on the research that Michael talked about and the FinMed model later today. It's going to go out in the follow-up email to this event, which will also include the slides, a recording of the webinar, and links to the materials and reports that Allison and Abby cited. So the first question I want to open up with is a question for Michael and Allison, and that's, could you describe, or what's your sense of the intersection or overlap between the coaching approach that you described, Michael, and the more information or literacy-based approach that Allison described? Do you see potential opportunities for those two approaches to come together?
Allison, I'll start, then I'll let you kind of fill in.
Sounds good.
I mean, I certainly we haven't talked about this in advance, so we'll see how we both come out. I mean, I do think, based on our experiences in coaching in other settings, is that there is this the relationship between people needing information and then using that information to achieve their goals. And oftentimes, people will start by learning something and then saying they want to work on their goals. Other times, they'll start working on their goals and realize they need to learn something. And so it's hard to predict when people are going to say, I need information versus I need a coach. I need somebody to help me think about goals and goal setting. I think they're both complements. And so the order of events of when you might access a coach versus when you might get education, I'm not sure. But for most people, they need both. And so really, it's not a matter of if they need it; it's a matter of when they need it.
Yeah, and I would agree. And I think, as I mentioned during my presentation, a lot of the work that we've been focusing on with, the particular work that I've been talking about in the presentation is just thinking about how that information is shared and recognizing that, that many people are just totally confounded by health insurance and cost, and just numeracy is a really challenging thing. And so really encouraging all of us to be thinking more about, it's not just the information, but how are we presenting that information? What are ways in which it would really be make most sense to the audience that you're talking to, and also to really think about that. So many of us, yes, literacy is affecting a lot of people, but health literacy and health insurance literacy is something that even those of us with education, post-secondary education, graduate school even, we still struggle with it. Even those in our office still struggle with it, and we deal with it every day. So I think always trying to present information in an accessible way, whether with our navigators or in a financial coaching situation, would always be a great way to go.
Thank you. So the next question we have is going to be for Michael. Have insurers or managed care organizations been involved in the design of FinMed? And then the person also noted that the insurers or the managed care organizations would have data on prescriptions, so we would be able to see who is compliant or not.
Right. Yeah. We've both with pharmacies, pharmacy benefit managers, and then also healthcare providers and insurers. And I think one thing we've learned is that these systems aren't as interconnected as we all might think. That, a doctor will write a prescription and may not know for a while whether or not you followed through in filling the script or not. We're a little better. The system's a little better at knowing when people fill a script and then it's due and they don't refill it. But oftentimes when a script doesn't go filled at all, it sort of falls off the radar. So I think what we've learned is that there's a lot of interest in this, but there's also a lot of finger pointing saying, well, it's the physician or it's the pharmacy benefit manager or it's the pharmacist or, sort of where in the sort of chain of events this intervention best works is something I think we're still trying to figure out. It's pretty clear that it's a hard thing for a physician or for a provider to really know how much you're even going to pay for your copay, given the variation even within a single plan. And so, it's a lot to impose upon providers. Pharmacies may be one of the better places to try to intervene, but that assumes you are in the pharmacy system. And so for people who are discouraged by the potential of a copay never even show up at the pharmacist, then we kind of, I think it is a challenge to try to figure out how to put yourself in a very complex system.
Thanks, Michael. I have the next question here for Abby. What opportunities do practitioners have to elevate the topic of health and finances to their existing funders and supporters?
Great question. I would invite them to share the brief that is at www.assetfunders.org. Feel free to connect funders directly to us. And in addition to that, we produced a discussion guide for funders, but I'm also happy to pass that along and include it in the resources that might help spark a more in-depth conversation in your local communities or regions around the connection of health and wealth, and some questions in particular that might be relevant for funders. We've actually had a lot of conversation as a network about how we help funders who may be on the verge of these types of investment or have interest but don't know where to start. So we're here as a resource. If I can be of assistance to help you further those conversations, please let me know. And Colin, I'll be sure to share our discussion guide with you if you'd like to post that as a resource for attendees.
Great, thank you. And I think we have time for one more question. This is also going to be for Abby. And this goes back to the site that you were describing. Do you know if the counselors there are trained mainly on financial topics, or can you talk a little bit more about what their training is?
That's a good question, and I'm not exactly sure. They're definitely certified, but I don't know specifically what training and certification they have. So that's something we can follow up on and get some more information.
Okay, thanks, Abby. I'm now going to turn it over to Hallie, who's going to close out the webinar.
Thank you so much, Colin. I would like to thank Sarah Willis, Michael Collins, Allison Esposeth, Abby Hughes-Holzclaw, and then, of course, Colin as well for their contributions to this webinar today, for participating in the question and answer session. Just as a reminder, the newly released report will be posted, as well as this webinar recording, on our CFS website, cfs.wisc.edu, and that will be shortly following the webinar. And then also please look for an email later today with links to these resources as well as the publications that Allison and Abby referred to in their presentations. Again, I'd like to thank everyone for joining us and have a great day.